Hey everybody, it's Caitlin. Welcome back to CoronaChat. Today is Thursday, July 23rd, and tonight we have two main stories to focus on, one a bit more serious than the other. So the first is about kimchi, and the second is about the CDC. So since we tend to talk a lot about the CDC, let's start tonight's show with kimchi. Over the last few weeks, you may have seen some articles floating around the internet claiming that fermented cabbage, either in the form of sauerkraut or kimchi, can prevent you from getting sick with COVID-19. And as an avid kimchi eater, there's mat kimchi and kaktuki in my fridge right now, actually, for those who are wondering. I was, of course, thrilled to see this news. But sadly, all is not as it seems. So it turns out that the paper that's being cited in talking about this fermented cabbage isn't actually a study. It's more like an op-ed published in a scientific journal. Now, journals do this sometimes. It's usually an opportunity for someone to kind of publicly throw some ideas out there to spur future research. And in this particular case, a group of nutrition researchers looked at a map of COVID mortality in Europe and tried to think about what might be different between countries with high mortality, like Italy, Spain, and the UK, and those with low mortality, like Germany. Now, most of us would probably say, well, there are lots of differences between those countries. But the differences that are most directly related to coronavirus probably have to do with the fact that Germany implemented strong preventative measures quickly and rapidly ramped up testing and contact tracing. But these authors actually hone in on something else. So they speculate that the difference has to do with fermented cabbage consumption, because countries like Germany and Austria are known for sauerkraut consumption, while countries like Spain and Italy are not. And they go on to claim that this is also why South Korea and Taiwan have had such low COVID mortality rates. And then they go on to say that other fermented foods like yogurt explain lower mortality rates in Turkey and Greece. The problem with this is twofold. First, people in other countries with high mortality rates also eat fermented food. Hello, Sweden with pickled herring, India with yogurt and pickled everything else, and the list goes on, right? And similarly, there are countries that haven't been as affected where, people are not eating as much fermented food, right? So this claim really isn't backed up by data. But the second issue is that just because people in one country generally eat more cabbage than people in another country doesn't mean that cabbage eating is what's protecting people, right? This is something that epidemiologists call the ecological fallacy. This is when we take something that applies on average to a group and mistakenly think that because it applies on average, it also applies to every individual in the group. So just because Germans in general eat sauerkraut doesn't mean that all Germans eat sauerkraut, or that they eat it every day or eat a lot of it all the time, right? So to figure out if sauerkraut or kimchi, or yogurt for that matter, actually protect you from COVID, we would need to randomize everybody to either eat the same amount of sauerkraut or kimchi or not eat any, and then see who ended up getting sick once they were exposed, right? So this is technically a testable hypothesis, but why would we test this hypothesis when there are other more plausible explanations that are backed up by evidence? The authors of the article acknowledge this by saying, quote, the more relevant factors are likely to be seasonal variations, immunity, cross-immunity, intensity, timing of measures, type, onset, duration, and measures of protection, end quote. Still, they say, quote, other factors like environment or nutrition should not be overlooked, end quote. This is a fair point if time and resources are unlimited, but there is only so much money to go around and people's lives hang in the balance. We need to make sure that our tax dollars are being invested in testing the things that are most relevant to containing the spread, not every single thing that could hypothetically be involved, right? And again, because time and people's lives that hang in the balance are not unlimited. Okay, so our second story tonight has to do with the CDC. And as you may have already heard by now, the US federal government has ordered hospitals to stop sending their data to the CDC and instead send them to a private company called Teletracker, which will then report the data up to the Department of Health and Human Services, also known as HHS. And lots of people have been freaking out about this on social media, but what does it really mean? So the first thing to know about is the difference between CDC and HHS, right? So the CDC technically is an agency within the HHS. And among other things, CDC is considered the kind of data and technical agency of HHS, right? They do things like count deaths and hospitalizations and provide clinical recommendations for how care should be provided and give states advice on how to manage outbreaks. Even though CDC is part of HHS, it has historically been very nonpartisan, non-political, and its outputs are independent and free from any kind of political influence, right? The Food and Drug Administration, or FDA, the National Institutes of Health, or NIH, and the Centers for Medicaid and Medicare Services, or CMS, operate similarly. Right? So for COVID, the CDC has been collecting data from hospitals all over the country and publicly reporting the number of hospitalizations on a rolling basis. In the absence of widely available, quick, reliable testing, many public health officials and government leaders have been using this hospitalization data to try to understand how the pandemic is evolving and where more resources are most needed. Many governors are actually using this data to guide their decisions about reopening. Now, one legitimate challenge with the CDC data is that there's been a week-long lag in getting all of the data collected and posted. And a lot of this has to do with the lag time between whenever hospitals enter data into the system, it hits the CDC server, somebody reviews it and calls the hospital back about any weird entries where there might have been an error, and then puts everything up on the public site. Making sure that these numbers are accurate takes some time. But these delays, of course, have implications for our ability to know what's happening on the ground and act. Now, HHS, the big federal office that oversees these agencies, including CDC, right, reports directly to the White House. So there's been some concern that data might not be as easily available as it was when it was published by the CDC. And an additional layer to this concern is that the work of collecting, cleaning, and compiling the data is not going to be done at HHS, but actually has been outsourced to a private company called TeleTracker. Now, this contract was apparently awarded back in April, and so there have been two parallel data systems operating for some time now. And this isn't necessarily a concern in and of itself, although one does wonder why we're paying a private company $10 million to do something a public agency already does. But, you know, the bigger questions that this raises are kind of transparency questions down the line. So, for example, if there are questions about the accuracy and completeness of something that the CDC does, reporters can file a Freedom of Information request, right, a FOIA request, and then ask an outside researcher to review the data. But a private company is not bound by FOIA, meaning that it could be harder to get a check on data if the numbers seem funny or if they disappeared altogether. There have also been some more mundane but still very important challenges in switching to the new system. Apparently, TeleTracker's system is different than the CDC one, which means that hospital staff are having to learn a new data entry system at the same time that they're being flooded by COVID patients. So the administration's order gave them just 36 hours to comply, or else risk losing access to critical resources, including supplies of remdesivir, which is the only drug that's been shown to have any effect on COVID patients. So it's been particularly hard for small rural hospitals to keep up. And these hospitals are already really understaffed and under-resourced, actually leading many of them to close in recent years, as documented by researchers like Katie Kozemanil and Mark Holmes. And with hospitals in rural areas already stretched thin, asking the folks working there to drop everything and learn a data system from scratch might be one ask too many. And indeed, states with large rural populations like Iowa have actually seen their data dashboards go completely dark with the change, meaning that public officials are groping around in the dark as they try to contain the virus, right? They're trying to make their decisions in the absence of any data. Hopefully, TeleTracker can work with these states and hospitals to get the data back online. But in the long term, we're going to need to think long and hard about the implications of having a private organization that's not accountable to the people having access to this data, rather than a public agency that's charged with protecting the people's health. So that's our show for tonight. Thanks so much for tuning in, and we'll see you all back next week. In the meantime, stay safe, take care of one another, and remember, we're all in this together.